Good day and welcome to the Foundation for a Healthy Kentucky Health Data Sharing Experiences from Kentucky conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Rochelle Seeger with the Foundation for a Healthy Kentucky. Please go ahead, ma'am.
Good afternoon, everyone. Thank you so much for joining us here today on this webinar, or if you're calling in from your phone, welcome. I'm thrilled to have three great speakers to talk about using electronic health data. I'm with the Foundation for a Healthy Kentucky. I'm honored to work on the data initiatives of the Foundation for a Healthy Kentucky. I work on the Kentucky Health Facts data website. I work on some other data reports, including the Kentucky Health Issues Poll, which is a really exciting project that the Foundation has sponsored since 2008 in partnership with the Health Foundation Interact for Health. And also I do this training and capacity building series we call Health for a Change. It's very exciting to see what's happening across Kentucky, all of the exciting stories and work that's being done to improve the health of Kentuckians, and I'm honored to lead this training series, Health for a Change. The Foundation for Healthy Kentucky's mission is to address the unmet health care needs of Kentuckians, and I think many of you on the call today are working in that same direction. Glad you're joining us today. The Foundation does its work by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. And for me, one of the great things is considering the data and how can we use data to move in the direction of improving Kentucky's health. And frequently when I'm talking about data and data sharing, I hear the challenge of, it can't be done, and then the conversation stops. So I'm thrilled to have three great speakers who will help us continue that conversation on how we can share health data in Kentucky. Just a reminder, the training series, this webinar and all of the webinars in the Health for a Change are on our Healthy Kentucky website. You can see the web link there. Our address is healthy-ky.org. We have great upcoming webinars, a grant writing webinar on May 23rd, a health equity webinar on June 20th, two Planning for Success webinars, so check the website to find out information about that in June and August. And then in August, we'll also have a Working with the Media workshop in Bowling Green, Kentucky. Be on the road August 16th. All of these are free and open to the public, so please join us then or forward the registration information on to your colleagues. Finally, I'm thrilled to partner with the Foundation for Healthy Kentucky, CETIC out of the University of Kentucky, Kentucky Cancer Consortium, and the Partnership for a Fit Kentucky to launch these two workshops working on community health coalitions. Tomorrow, I'm thrilled to be in Muhlenberg County, so if you're on the line today, maybe I'll see you there tomorrow. And May 17th, we'll be in Clark County. Again, these workshops are free and open to the public. So I'm thrilled that you all have joined us here today. You can check out the Foundation's social media. I tweet out of Kentucky Health Facts, and my colleague tweets out of Healthy Kentucky. And our website has all the information about what we're doing, our projects, our research reports, and also the schedule for this training series. Now I'm thrilled to turn the call over to Denise Chrysler with the Network for Public Health Law. Denise will be talking about a newly released report, and as soon as I saw that report, I knew I wanted to hear more from Denise. So please help me welcome Denise. Go ahead.
Thank you so much, Rochelle. It's good to be here with everybody. Rochelle first asked me to mention some information about the Network for Public Health Law. I work for the Network for Public Health Law. We have a national office, and we have 5 regional centers, and that helps us to serve people from across the nation. My particular region that I direct is the Mid-States region, and Kentucky is one of the states that we serve. So I would really appreciate hearing from all of you. Just some of the services that we provide is first legal technical assistance. So if you look, can't quite use this, okay. Ask a question. If you click Ask a Question on our website, and the URL is down at the bottom of the page. We will be able to assist you with strategizing on legal issues, identifying resources and experts for you, and providing limited analysis. Depending on the issue, we can usually assist health departments and nonprofits for up to 4 hours with technical assistance. If you have large projects or need extensive research and analysis, then we need to be talking about, finding some sources of funding. But our mission is to promote and support the use of law to solve public health problems. We serve governmental public health. We also assist nonprofits and other agencies and universities and advocates and basically anybody who is promoting health to improve communities. Since we have so many areas of public health that we assist with, everything from drug abuse to emergency preparedness to maternal and child health. We have areas that each of us specialize in. My Deputy Director, Jennifer Bernstein, and I both specialize in legal issues related to health information data sharing. So you can see the topic right there. Also, we provide resources and training. Today is an example of a training. I provided to Rochelle 2 resources to make available to you. One is really helpful, I hope, it's actually available on our web in a form you can complete, which is kind of information that you need to provide to your attorney or privacy officer so they can help you navigate the law with regard to legal issues around data. So it'll ask you, what data sharing, where did it come from, sharing with whom, what data elements, is this the minimum necessary, and a number of questions, factual questions you'll need to be able to answer in order to then apply the law. And I also provided you with a resource list on lots and lots of resources with regard to de-identification, because de-identified information is usually, you can freely share that kind of information without a consent or authorization, but then what is considered to be de-identified? And part of that resource list is a number of state policies that are online that have, for example, suppression policies and policies about the public release of information and information that hopefully will be helpful. So now, with that intro, let's talk about using electronic health data for community health. We all, I'm sure on this call, want more timely, frequent, and local data to do our jobs better. As we, know, often our data is quite old. It's often aggregated to the year. It's for geographically large areas. And to really impact public health, we need to be able to have, I assume I would call it more granular data. So when you have inadequate data, it's challenging for us to spot key trends. It's difficult for us to recognize opportunities for intervention. It's hard for us to generate urgency or political engagement, and it's impossible for us to assess the public health impact of interventions in a reasonable time frame. So data from healthcare can address many gaps, and especially data from emergency departments and ambulatory care settings, and particularly data from electronic health records. So I'm really pleased one of our speakers today will be talking about health information exchanges. So what's holding us up? There's many things that hold us up. One, interoperability, technology, culture about data sharing, and cost to deal with all the issues, and many, many, many other things. But in my role as a lawyer, what I often hear is law holds us up, and in particular, the HIPAA privacy rule when it comes to data from healthcare providers. And the question is, or the comment is usually, we can't do that. HIPAA prevents us from doing that. And I confess it can be a very intimidating law, and I spent many years working with it, including as a privacy officer, so I understand fully how it can be that monster that prevents you from going forward. So with that in mind, the de Beaumont Foundation published a report, and I'm one of the co-authors on the report, along with Josh Sharfstein and our colleagues at the Network for Public Health Law and the University of Michigan School of Public Health and the Johns Hopkins Bloomberg School of Public Health. So we prepared this report, and I would urge you, if you haven't already, to read the report. It is based on 6 use cases, and it also has a section where we worked as hard as we could in non-legalese to explain the privacy rule as it comes to data sharing from healthcare providers to public health. And then we applied the HIPAA privacy rule to 6 use cases. In addition to this report, the All-In Data for Community Health put on a webinar in March, and then they just had a follow-up webinar yesterday. Here's the URL, where Josh Sharfstein and I go through the different use cases and explain the applicability of HIPAA and demonstrating that HIPAA for those particular use cases should not be a barrier. So these are the 6 use cases. I took a screenshot of this so I know it's not a clear thing that you can read, but what you can see is as we go on from use case to use case, the list of data elements at the bottom gets longer and longer, and the use cases become more and more complex. The first one, for example, is fairly simple and straightforward. It involves data that is not individually identifiable, and it's for your main public health functions of surveillance and public health education. And then as we go on to each one, the use cases get harder and harder, and at the end we're dealing with issues such as is this public health practice? Are we disclosing information for research? And then lots of other issues in between. So we distilled our analysis and application of the HIPAA privacy rule down into some just 4 or 5 basic questions. And this is for purposes of disclosure to a health department to improve the public's health. So is this legal under HIPAA? We first want to know, is the entity providing the data covered by HIPAA? If no, then it doesn't apply. If yes, it does. And then is the data protected health information? HIPAA does not apply to de-identified information. That's one reason I provided you with the resources on what is considered de-identification. So if it's de-identified, then HIPAA and most other privacy laws would not apply. So if HIPAA does apply, does HIPAA require or permit the data to be shared with a public health agency? And there are public health provisions in HIPAA that are pretty broad to allow such sharing, including of identifiable information. But for that identifiable information to be shared, has to be related to a legitimate public health purpose. So that's our next question. And it needs to ask only for the minimum necessary data. So I selected just one of the use cases to illustrate the application, or to illustrate how the report is structured. This is like a medium level as far as complexity. It's pretty standard. The health department requests from the emergency department weekly data on each childhood asthma admission, including the date, the age and years, gender, race, ethnicity, street address, name, and contact information. And what the health department wants to do with this is to develop a registry of children admitted to the hospital for asthma. And those that are most frequently admitted will be offered home visits and care coordination. So I will be going, I hope I can remember all the details here, because the first question is the entity that's providing the data covered by HIPAA. Yes, HIPAA applies to all health plans. Most healthcare providers, whether a healthcare provider is covered depends on if the healthcare provider transmits electronic information basically related to determining eligibility for payment or payment for health care. So that would include an emergency department or a healthcare clearinghouse, which translates information from a non-standard form to a standard form or vice versa for purposes of payment. And then it's the business associates of a covered entity. So yes, the hospital emergency department is covered by HIPAA. So the next question, is the data to be shared protected by health information, or is it to be shared, is the data to be shared protected health information? So protected health information we would expect to include all of our personal identifiers, our name, our street address, our phone number, our email address, social security number, and all those sorts of things. But it also includes demographic information of certain types of demographic information, unless you can demonstrate with an expert that there is very small risk that an individual can be identified. It also includes a lot of dates except for a year, like a birth date. You can have age by year, but not a birth date, dates of admission, discharge, etc. And so it may include aggregate data. It just depends, and it depends on whether it's information that either identifies the individual or for which there is a reasonable basis to believe that an individual could be identified. That's why we have policies about small cell size and different policies about release of information. So then, does HIPAA require permit the data to be shared with a public health agency? HIPAA has two public health provisions, and one allows a covered entity to provide fully identifiable data to a public health authority, which would be your governmental public health, and also its authorized agents. So if public health contracts with a community-based organization to assist the health department in carrying out its responsibilities, or if another governmental entity enters into a memorandum of understanding with a public health agency to help, then that entity would come within the ambit of being able to receive identifiable information. And the use must be for a public health purpose, and it must be the minimum necessary needed for the public health purpose. Now, I put a little paragraph in there also about a limited data set. A limited data set can be disclosed to any entity, including a community-based organization, as long as it's for public health purposes, or it could be for research or healthcare operations. And this is not personally identifiable information, but it makes the data a lot more meaningful because it has geographic identifiers and dates. And to receive that information, the community-based organization would need to be entering into a limited data set agreement with the emergency department and agreeing to certain things to protect the information, including that it would not try to identify any individuals. So on the use case, would you like a home visit? The HIPAA analysis is, since this is a public health entity, there's a clear need for the data. The description is the minimally necessary data elements for fulfilling a public health activity and a plan to use the data without disclosing more. And there's a plan to use the data without disclosing more than is needed. So in order to have a registry, in order to reach out, provide education and services, you need to have individuals' names. You need to have their addresses or ways to contact them and those sorts of things. So in this instance, identifiable information is appropriate. So in this instance, it would be perfectly acceptable under the HIPAA privacy rule to share this data. So as I said, this is just one of 6 use cases. There's 5 others with various issues. The one point I wanted to make And if you think of, say, registries related to diabetes or any other registry, or if you think of, say, immunization and reporting immunization data to a health department, or syndromic surveillance, or anything else, HIPAA will allow information to be shared both where there's a reporting duty, but also if there is not a reporting duty, but the health department is vested with legal powers under law to collect the information and to use it for the public's health. And every, if not most, if not every health department has that kind of broad authority. So in order for a covered entity to share information, there does not have to be a mandate. There does not have to be a requirement. It could be voluntarily provided as permitted under the public health provision in HIPAA. And when I was a privacy officer years ago, in order to help the emergency department or the hospital feel more comfortable with sharing data where there was not a mandate, I would often write a memorandum to them explaining what the health department wanted, why it wanted it, explaining what HIPAA allows, talking about the purpose it would be used for. And often the hospital would feel that that was their due diligence. They had the statement, and the law does allow a covered entity to rely on the representations of a health department as to their need for the information, their legal authority, and the minimum necessary, as long as that's a reasonable, what is provided is reasonable. So I would just like to acknowledge my co-authors on the report, the de Beaumont Foundation for funding the creation of this report, the All-In Data for Community Health for providing a webinar on this report, and finally the Foundation for a Healthy Kentucky for hosting today's webinar. And with that, I will turn this over to Rochelle.
Thanks so much, Denise. Great information, and I'm sending out to all of our participants who are logged in on the web, again, that link. The resources that Denise mentioned are already posted to the Foundation's website there at the Health for a Change website, so that'll be ready for you. And again, also just a reminder that participants can chat in questions for our speakers, and if we don't have time on the call today, speakers will also try and get you answers to your questions. So feel free to chat in questions to us if you're logged into the web portion of our webinar today. So thanks so much, Denise. And on to our next speaker. I'm honored to have Karen Chrisman. She's with the Kentucky Health Information Exchange, and she will be sharing what's happening in Kentucky regarding data sharing. Karen, welcome to the call.
Thank you. I appreciate that. I was very excited to read this study, and I would encourage everybody on the call to look at that. It is wonderful information if you're a public health department or even if you're a covered entity thinking about issues in reporting to a health department. With this presentation, the KHI is the Kentucky Health Information Exchange. It is a statewide health information exchange, and it has clinical healthcare data sources taken from an electronic medical record of different covered entities that have joined the exchange across the state of Kentucky. I'm going to be talking about data that is supplied by the Health Information Exchange to the Kentucky Department of Public Health. I wanted to give the audience an idea of the scope of the information that is within KHI. And you can see here, broken down by region, the number of providers that when we say they're live, that means they're providing information to the Health Information Exchange, and the number of data feeds that we currently have in progress. These sources can be doctors, hospitals, community mental health centers, emergency medical services, or corrections facilities that are providing healthcare services within the state. This is another representation of the network that we have. And if you look on that upper left-hand corner, you're going to see the information that goes to public health. Immunization Registry, the Cancer Registry, electronic lab reporting through Public Health's NEDS system, and syndromic surveillance. This is also representative of the kinds and types of providers that are using the Kentucky Health Information Exchange. You'll see down in that corner the eHealth Exchange. That is the national eHealth Exchange that KHI is also connected to. This is a representation of what we refer to in KHI as our platinum participants. What that means is these are providers that are working with KHI to do what is considered the gold standard of interoperability. So when we talk about interoperability across the nation, these providers are using a healthcare exchange standard that is the most robust standard that we currently have. Now, this is our platinum reporting by county. This shows you the number of counties that we have that are actually using this connectivity to the exchange. This is also another representation of the scope of the information that's in the Kentucky Health Information Exchange. These are the state's community mental health centers. However, because of the information that is in the electronic medical records of these centers, this information relies solely upon the consent of the patient. If the patient does not consent for their information to be shared, it won't be found in KHI. One of the things we talked about earlier is immunization reporting. This is the representation of immunization reporting in the state of Kentucky today. These are the number of providers that are actually submitting data through KHI into the Kentucky Health Information Exchange. The reason that Kentucky is using this model is it is a cost savings for the provider in having to provide that interchange. If they provide it to KHI, KHI normalizes data and then sends it on to the immunization registry. It's a savings mechanism for that provider in the work that is required to establish that connectivity to the health or to the Kentucky Immunization Registry. We also in Kentucky have the ability for a provider to query, not just submit immunizations to the immunization registry, but to query for those immunizations. These are currently the healthcare systems in our state that are working on this connectivity. This is a relatively new service that's provided by KHI, so our expectation, there are going to be many more healthcare providers in the state of Kentucky that can actually use their electronic medical record, query the Kentucky Immunization Registry, and pull the information about the immunizations directly back into that record, adding efficiency and time savings to the provider and also giving them access to all of the immunization information that is in our Kentucky Health Information Exchange. This is syndromic surveillance by county. Again, this is a scope of the amount of syndromic surveillance that is available to the state of Kentucky. This feed actually comes into KHI. It is de-identified. KHI always receives protected health information, but in this particular feed, we de-identify that health information according to the standards that are provided to us by the Centers for Disease Control. It is reported through Public Health's NEDS system to the CDC, but the CDC in turn provides a dashboard and reports to the Kentucky Department of Public Health of the results that come out of this particular connectivity. The legal authority that KHI and the Kentucky Department of Public Health use for this reporting, many of the reports that are done are voluntary. It's much easier for a healthcare provider to do that reporting electronically through KHI and then that be directly fed into the Department for Public Health's system. This is electronic laboratory reporting to the Kentucky Department of Public Health. That was actually created by Kentucky regulation. There are certain conditions that public health wants KHI to receive those conditions, pass them on to the Department for Public Health. As it currently exists, there are only two sections of this regulation, 902 KAR 2, 020, that require electronic laboratory reporting. However, there is enough flexibility within the regulatory system that when the Kentucky Department of Public Health decides that they want to expand that, they will be able to do that. This is an interesting use case that Kentucky has had as far as KHI data and the information that is being reported to the Kentucky Department of Public Health. Because we were doing electronic laboratory reporting and these laboratory reports were available in KHI, the last legislative session, no, the previous to the last section, this statute was required. And it requires reporting to the Cabinet for Health and Family Services, the Office of the Inspector General, all positive toxicology screens. This information comes out of KHI, and then it is routed to the OIG. This is an attempt to provide additional information that will allow Kentucky to evaluate the scope and the nature of the drug crisis within the state. This is a representation of the amount of electronic laboratory reporting that is coming into KHI currently. We have scoped this project and are concentrating on hospitals. So in this, you will see we have 52 hospitals. We have 27 that are in process. All of our Kentucky hospitals will be doing this reporting electronically. All we're waiting on is their readiness. Many of them are having to make changes in that laboratory feed. So this is the scope of the actual information that KHI has available in areas that are of particular interest to public health. The next slides we have are probably the most robust use case of the information that is in KHI to date. This is information that comes through our syndromic surveillance feed. It goes to an agent of the Kentucky Department of Public Health called KIPRIC. That's the Kentucky Injury Prevention and Resource Center. These individuals have been a tremendous resource for KHI because they have worked fabulously with KHI so that we are able to improve our data quality to meet the information that KIPRIC needs. And they use this information, as you can see here, to do studies and to provide current documentation of what may be occurring. This was a study of synthetic marijuana use and overdoses within the Fayette County area. And the next one that we have is heroin doses, again in the Fayette County area for the time period. And KIPRIC was able to establish with that data feed that the information is dire. They will be able to trace it. They used KHI information, and as you can see here, the EMS runs. KHI has since that time added to our information a feed with the electronic medical services in the state of Kentucky. So I'm seeing some hands raised or some questions that have been written in about the white counties. I'm going to go back very quickly when I can get back there. Yeah, let me just try it this way, back to our white counties. So if it's a white county, don't necessarily assume that it is that we have no reporting at that time. It is also possible that there is not a hospital that would be subject to the reporting. And secondly, we're having white counties here. If you will see, this is our individuals that are submitting data. It could be we have in process, so there could be that these counties are our in-process counties. Now when we get here to our platinum reporting, with that, you can assume that it's not that there's no county there reporting, it's that they are not reporting using this standard. Again, this is the platinum reporting by our counties, and you can report to KHI and share information with KHI and not use this standard, but this is the most flexible. It has the greatest amount of information that we can provide for you. So this is the standard that we have that is really a preferable standard. So I also want to give credit on this slide to, this is the staff at Kiprick. If you search on these for this information, you will actually be able to find the report and the conclusions that were reached by the Kiprick staff at the College of Public Health at the University of Kentucky. And we have a very close working relationship with that group because, again, they are helping us make tremendous strides towards our data quality within the Health Information Exchange. So I also see that I have some hands raised right now. Do we want to address those or wait until the end?
Thanks, Karen. Let's just go ahead, and if those who have their hand raised could chat in their questions, we can hopefully get to those in a moment once we get through our other presentations. So if you want to go ahead and chat in your questions through the chat feature, that would be great. And Karen, thank you so much for your presentation, and thanks for answering the question about the white counties in your maps. I had that exact same question as well. So thank you so much for joining us here today so we could learn more about Kentucky Health Information Exchange, as we fondly call KHI here in the state. Next, I'm thrilled to have us join on the call here Yu-Ting Chen. Yu-Ting is with the Louisville Metro Public Health and Wellness, and he'll be talking about the new project that they're launching and some of the data initiatives they had. Go ahead, Yu-Ting.
Okay. Hello, everyone. My name is Yu-Ting Chen. I'm an epidemiologist at the Louisville Metro Department of Public Health and Wellness. So today I have some technical issues, so I will have Rachel to help me to move on slides. So today in my presentation, there are three main components. One is the substance use misuse plan that we have here in Louisville Metro. The second one is we will talk about the ODMAP project we have, and then I will talk about the data warehouse project. Next slide, please. The current national opioid epidemic has been called the worst drug crisis in American history. According to the CDC, during 2015, there were 52,404 overdose deaths in the U.S., including 33,091 that involved an opioid. In 2016, an average of 115 people in the U.S. die every day from an opioid overdose. Like much of the country and the region, opioid and other drug use in Louisville has increased over the past 5 years. Hospitalizations and emergency room visits due to severe acute drug poisoning rose from 2012 to 2016, and same as the drug overdose deaths. Next slide, please. Substance misuse is the harmful use of substance for non-medical purpose. People often refer the term substance misuse to illegal drugs. However, legal substance can also be misused, such as alcohol, prescription medications, caffeine, nicotine, and so on and so forth. So when we were conducting this substance use plan, we also pay attention to tobacco and alcohol addiction as well. Next slide, please. Starting in June 2017, Mayor Fisher tasked the Health Department to conduct a citywide plan to accelerate our effort to combat the crisis. So we began the work by convincing community members in Louisville, including people in recovery, leaders of nonprofits, law enforcement, healthcare providers, social workers, school officials, and many more. Those community members spent less for working in 4 groups, focusing on primary prevention and education, opioid overdose prevention, recovery support, and spending access to treatment. They review the data, explore best practice and examples from our own city and other communities, and then discuss potential solutions. Can you go to slide 6, please? The next one. So this is actually my thank you list for our data sources and partners. As you can see, CDC, KDPH, Kentucky Office of Health Policy, Vital Statistics, as well as KHI and KBRIC and CASPEN and Police Department. That's because when we get in the data for this plan, we actually collecting data and the reports from each of those agencies. So in the report, we were using a lot of vital statistics, mainly the death records and hospitalization data, CASPER data, data from JCPS, Metro EMS, as well as birthers. Next, please. And the next one. So substance use disorder is preventing fatal for many Louisville residents. So overdose death in Louisville has risen every year since 2011. Regardless of drugs, Louisville's overdose death rate is more than double the national rate. In 2015, Louisville's overdose death rate for all drugs exceeds that of Kentucky and continue to climb. As you can see in the map, although you found a highly concentrated overdose death at the west or southwest region of Louisville, but overdose deaths actually occur in nearly every Louisville zip code. Next slide. Can you jump the slide to the tobacco one, please? Okay, so also from the birthers data, we can see the smoking prevalence rate is declining, but Louisville, the prevalence rate in Louisville area is consistently higher than the national rate. Next slide, please. So this is the data from JCPS. We still found, it's a huge decreasing of using cigarettes in JCPS students. But for this data, they don't ask questions that relate to e-cigarette, and then we all know, the younger population tend to use e-cigarettes now. Next one, please. So in this figure, you can see the alcohol-induced death rates in Louisville Metro are consistently higher than the state, as well as the national rate. The next one, slide please, and the next one. So, same thing show up at the hospitalization data. We can see alcohol-related inpatient hospitalization occurs everywhere in Jefferson County, not only the west part of Jefferson County. So next, can you jump to the OD map, please? So this is the project that currently Louisville Metro is working on. It's called OD map, stands for Overdose Detection Mapping Application Program. This is the program from the HITA, which is High Intensity Drug Trafficking Area Program. This program is a federal program administered by the White House Office of National Drug Control Policy. So ODMAP provides real-time overdose surveillance data. This is really similar to the essence that you see data from each hospitals through K-High. But in this program, it's actually asks the first responders on the scene to input the data. So you can see on your left-hand side, there's the app that on the smartphone that like EMT will use. Initially, it only asks 3 questions: the location, whether it's a non-fatal overdose or fatal overdose, and then how many naloxone kit you use on the scene. So the first responder on the scene will input those 3 questions, and it will feed to the database. And at the back end, as a back end user, I will be able to see it showing on the map, and then as well as I will receive a weekly report from KDOT showing the trend and the components of or categories of each fatal, non-fatal, as well as the naloxone key used. So early last year, KDOT was invited to give a presentation on ODMAP to the leadership team in Louisville Metro. We start to adopt these tools in fall 2017, and then therefore we hire an ODMAP analyst to coordinate this program. Some challenges we have for this one is the first responders, oftentimes they are facing really emergency situation. So when we are asking them to input this data, is adding more text for them, even though it won't take very long. But we do have some like pushback from the first responders saying oftentimes they even forget to input whatever we ask them to input. So one of the solutions we found is EMS will try to extract data from their electronic health records to feed into the database directly. So those 3 components can extract from the database directly. And also another challenge we were facing for this tool was this is actually needs input from the first responders. So, but even in Louisville Metro, we have different agencies as first responders, like Sub-City Police Department, LMPD. We have commercial EMS as well, and then we also would like the emergency room staff will be able to input data for us. So the data coordinator is actually working with different partners to get them to buy in to use this tool, so we can really see a comprehensive results of data in our region. Next slide, please. In River Metro, we also have a working group called Data Governance. It's actually the members of this data government is the data person from each different department, like me from health department, and we will have data people from EMS, data people from LMPD, the police department, the data people even from the park department. So under this framework, we have several working groups that's working on data-related issues. The main thing I want to point out is the data warehouse working group. We want to set up a centralized place that each department can feed our data to that. So, me as a epidemiologist at the health department, I can access to the data warehouse, then access to the police data, the coroner's office data, the correction data, and so on and so forth. But by doing that, we also need to know what data that each department have. So we have the inventory group that will work on list detailedly about each data from each department. And also we need some standardized policy on certain issues. So when we are collecting data, every department is collecting data with standards. So for example, like here we have sex, gender, street address, race, nationality, and so on and so forth. So this is just a data group that we are currently working together and get the data that each department is collecting more meaningful use. Next slide, please. So this is the flow of how we see the data will flow. So each department will collect the data. Of course, each department has its own storage where they store the data, and they can use the data from there as well. But once they clean the data, they will feed the data to the warehouse. And then at the warehouse, me as other department staff, I will be able to assist the police department data from here as well. And then, for example, if I want, I can link the police data with correction data, and then link to, for example, EMS data or the coroner's office data, and do further analysis or even do a predict analysis as well. And because the data in the warehouse is supposed to be clean, so if it's not HIPAA violate, then we can even open this to share with public as well. Next slide, please. So, okay. So for the data warehouse, one thing we also would like to do is try to, also link to different data sources like criminal justice system data or treatment data, even school system data. So when we are looking at the overdose case, we not only see the data like from EMS or from police office, but we can also see the live court of this person and try to do more predict analysis from there. So other data sources we also use here is the SN and NET. And yeah. Now, next slide, please. Oh, here is my contact information. If you guys have any questions, you are more than welcome to reach out to me. Thank you.
Yuting, thank you so much for sharing that. It's good to see that we were on a data call and we saw some flow charts, so that's a good thing. And you know, just a handful of groups that you want to connect with, so thank you for your presentation. And in the last moments of our call, I want to turn it back over to Denise Chrysler with the Network for Public Health Law to make some concluding comments. Go ahead, Denise.
Thanks, Rochelle. Thank you, Karen and Yuting. Just as my last slide, a reminder of the questions about, is this legal under HIPAA? But Karen brought up something I just wanted to hit is I've talked about the applicability of the HIPAA privacy rule. HIPAA allows a lot of flexibility and voluntary reporting, and Karen talked about that, but she also talked about obtaining consent for behavioral health and mental health data. And HIPAA is not the only law. And when you especially are dealing, for example, with substance use disorders, there's Federal Law 42 CFR Part 2 that if there is federal funding, that is very restrictive. It doesn't have the kind of public health acknowledgement and recognition as HIPAA and many other laws do. So it's always important, as Karen talked about, and Yuting talked about all of the multiple data partners, all these sources of data. And when I'm going through data sharing scenarios and navigating the law, it's always an issue of following each data source and each data stream, identifying all the laws that are applicable, and then from there, you know, navigating and hopefully finding a way to get to yes. So that concludes my remarks, and over to you, Rochelle.
Thanks so much, Denise. I learned a lot on this webinar, and I think the most important thing is that there's a lot of great people working in Kentucky, and Denise, who's can work in Kentucky but is working nationally, who can help guide us so that if we get the response that the data is not permitted to be shared under HIPAA, then we know where to go next to get more information and to learn how we could possibly work through those challenges so that we can share data and improve the health of Kentuckians. I will send out a post-event survey on our event today. I'd love to hear your feedback. Please take a moment or 3 minutes or so of your time to give us feedback on what was interesting to you, what you learned, and then I welcome your suggestions for future Health for a Change training events just like this one. If you see a good report and you want to hear the speaker, as I did with this report from the Network for Public Health Law, let me know. I would love to share this information with our Kentucky audience. Here's my contact information. Please feel free to call on me if I can be of help with anything. And finally, the Foundation for a Healthy Kentucky's website is here. All of these slide decks and Denise's resources that she shared with us will be posted to the Foundation for Healthy Kentucky's website. Under that Events tab, you'll see the Health for a Change trainings. Reach out to Yuting, Karen at KHI, and Denise for additional assistance so we can move forward on some of these projects we're working on to improve the health of all Kentuckians. Again, thank you to our speakers for sharing their wealth of expertise with us, and to all of the participants on the call, have a great afternoon. Thank you for joining us.